Welcome to Lab Voices. We're going to talk a little bit about hepatitis B. So grab your headphones and have a seat. It's my privilege to welcome Dr. Joshua Hayden from Cleveland Clinic. He's the head of clinical biochemistry there. Previous to Cleveland Clinic, Dr. Hayden was at Norton Healthcare, and he was the chief of chemistry there. He was also an assistant professor at the Weill Cornell Medical College. He was the director of toxicology and therapeutic drug monitoring at New York Presbyterian Weill Cornell Medical Center. He completed his clinical chemistry fellowship at the University of Washington, and he did research at MIT before that. So please help me welcome Dr. Joshua Hayden.
Thank you, David. And thank you all for being here. As we're going to be spending some time today talking about best practices for hepatitis B testing and interpretation of results. So why are we talking about hepatitis B? Let me start with my disclosures. I always forget that. I am here with support provided by Abbott. I'm presenting at the request of Abbott. The views and opinions in the presentation are mine, and any results, findings, or conclusions are reflective of my experience and should not be considered a product claim. Individual results may vary. This presentation is not intended to represent or guarantee any laboratory will achieve the same or similar results. So, let's try again. Why are we talking about hepatitis B today? Right? Just to put it in perspective in terms of the global burden of hepatitis B, we have just over 250 million individuals worldwide chronically infected with hepatitis B. That works out to be about 3.5% of the global population. And you can see on the map the distribution of the various prevailing genotypes, which differ by the regions. You can also see the different distribution of chronic hepatitis B infection in children, with perinatal transmission of hepatitis B being the primary mode of transmission for spreading hepatitis B. So what are we trying to do about this? If we look at the cascade of viral hepatitis prevention, diagnosis and care, and treatment, we start with a large graph, which are all the people which are infected with hepatitis B. The very first step is getting those people reached with prevention activities and getting them tested. Once we get individuals tested and we can identify those who are infected with hepatitis B, we can start to ramp up our prevention strategies, as well as also begin to start care and treatment strategies. Right? The WHO has actually set a goal of identifying 90% of those individuals who are living with hepatitis B by 2030. And last I looked, we were not on track to hit that goal. So a lot of work left to do, and most of it starts with proper testing and recognition of hepatitis B. Because once we recognize it, we actually do have curative treatments, right? We can achieve a functional HBV cure, which is defined as undetectable hepatitis B surface antigen and undetectable HBV DNA in serum, with or without the seroconversion to the positive hepatitis B surface antibody. And this is associated with the resolution of residual liver injury and decreased risk of hepatocellular carcinoma, which is a major cause of the mortality in hepatitis B positive individuals. So to start to detect these patients, we have a variety of recommendations for testing. CDC actually recently updated their test recommendations, and those are shown here as we talk about who should be tested and how often they should be tested. The first big recommendation is what we call universal hepatitis B screening. So that's any adult over the age of 18 should be screened for HBV at least once in their lifetime. They also recommend any pregnant woman should be screened with each and every pregnancy. And then there's more frequent periodic testing for susceptible individuals. And susceptible individuals would be those with risk factors including current, former incarceration, infection with hepatitis C or other STIs, or individuals with multiple sexual partners. In addition to updating their recommendations for who and how often to test, CDC has new recommendations for how we should do our testing. And in particular, they're now advocating for the use of the triple panel test. So they have always recommended the inclusion of hepatitis B surface antigen, which is effective for identifying active infection, as well as testing for anti-hepatitis B surface antibody, which can determine susceptibility to HBV, as well as vaccination or previous infection status. And they now recommend the inclusion of total anti-hepatitis B core antibody. This is helpful because it can indicate individuals who have been previously infected and those who might be susceptible to reactivation. And that's something very important, especially as we're moving to more and more use of some of these immune modulators, which can suppress the immune system and lead to reactivation of hepatitis B. So knowing about the previous infection is very helpful. So how do we start to put these recommendations into practice, and how do we start to interpret the results of some of these tests? So I thought it might be helpful here today to just go through 4 patients and talk over some of the things you might see as a clinical laboratorian and some of the questions you might get from your providers. So let's start with case number 1. Case number 1 is a 43-year-old heterosexual male, presents for initiation of care. No history of illicit drug use, incarceration, unprotected sex, occupational hazards like exposure to infected fluids, but also no history of prior hepatitis B viral testing on record, right? So what, if any, testing should be ordered on this patient? And this is where our universal testing is the recommendation, right? While this patient might not have any risk factors, the fact that they have no documented history of being tested for hepatitis B means that they should at least once in their life get tested, and in particular, get tested with that triple panel test. So the HBV surface antigen, surface antibody, and a core antibody as well, right? This is not something we're seeing taken up nearly as much as we were hoping, so I wanted to include that one. It seems straightforward, but remembering the importance of universal testing and looking at that in your health system can be impactful. So let's look at case number 2. Case number 2 is a 33-year-old G2P1 female coming in for routine prenatal care at 11 weeks gestation. Her OBGYN did an excellent job testing with the triple panel test for hepatitis B. And in general, I don't know what it's like in your health systems, but we find that our OBGYNs are very, very good at following the guidelines, with a large percentage of our ID serology testing coming from OBGYN. They're ordering it appropriately. There's probably a lot of others who should also be ordering it. So in this patient's case, we have a non-reactive surface antigen, surface antibody, and a non-reactive core IgG, but a reactive core IgM, right? So how do we interpret these results with this isolated reactive core IgM? What could that possibly mean for this patient? In order to talk through that, I thought it might be helpful to go through some of the patterns of results you might see, and then we can talk at the end about how we would consider this patient's case, right? So I think one of the more straightforward patterns is the pattern of acute hepatitis B viral infection. So that's where we're going to have that reactive surface antigen as well as a reactive core IgM. So that's not exactly this patient's case because we only had that isolated core IgM that was reactive. If we had the reactive surface antigen as well, that would be fairly straightforward for acute infection. So I don't think that's the case here yet. We also have instances where we have a reactive Hep B surface antigen, and that's from recent vaccination. We've been encountering this quite a bit in our health system as they're trying to get patients through the encounter faster and faster. Sometimes they're putting the needle in the arm to inject the HBV vaccine, and then they're putting another needle in to draw blood to test for the presence of the hepatitis B surface antibody or the triple panel test as recommended, right? And so we do encounter this a fair bit, and you have that isolated reactive surface antigen most likely from recent vaccination. You can't rule out alternative explanations, So good to keep that in mind. We then also have the chronic infection pattern, where we're going to have that reactive surface antigen and a reactive core IgG, right? This is a patient who is chronically infected, has developed a serologic response as evidenced by the core IgG, but still has the persistent HBV surface antigen. We then have another case where the patient would be considered susceptible, so never infected, but also never vaccinated, right? So that would be the non-reactive surface antigen and non-reactive antibodies, right? One thing I want to pause and just mention here is for you to think about how this result would be flagged in your electronic medical record. Very often when we think about flagging laboratory results, we think about flagging things which are quote-unquote abnormal, right? So they're outside the central 95%, so your sodium is slightly above or below the reference range, right? And I'm certainly not going to argue with you that a normal person should not have a reactive surface antibody. So many labs will consider a non-reactive normal. I would push back on that because the reality is I think our flagging of results in the medical record is more about triggering a necessary clinical action on the part of the care team. And I would consider a non-reactive surface antibody, meaning an individual who is susceptible and could get vaccinated, is an actionable result. And so that's something we've been working on, is to make sure that these non-reactives, which should trigger some clinical action that is in the best interest of the patient and our communities, because remember, we're talking about communicable diseases. So every patient who is susceptible is a patient who could then transmit, right? Those are things that we want to flag. Happy to have that conversation with you later. If it gets heated, you'll have to get me a drink, but that's okay. I'm fine with that. Probably the most common pattern of results that we see, especially in the OBGYN population, is going to be this immune due to vaccination, right? Where you have this isolated surface antibody that's reactive, non-reactive core antibody pattern, non-reactive surface antigen, right? Now I'm going to mention that we can differentiate this immune due to vaccination because we have that core IgG and IgM, right? And so if, for instance, we have this patient, our patient's case, where we only have the isolated core IgM, that's not entirely consistent because we're not seeing that reactive surface antibody, which would indicate past infection, right? But of course, we know that the more lab tests we order, no matter how good your lab results, your lab tests are, you're going to end up having unexpected results, right? Every test has rates of false positives, false negatives. So of course, you could ask, could this be a false positive? And I think that's a possibility. So then, of course, you know, my mentor, Jeff Baird, used to always say, if you order a test you don't need, you're going to get a result you don't want, right? That's just sort of how it works, right? So why would we order these if we're just going to cause ourselves confusion? And the answer is because we actually need these core antibodies to differentiate those patients who are immune to hepatitis B from immunization and patients who are possibly immune due to that resolved infection, right? So you'll notice this pattern looks very similar to the immune due to vaccination with the reactive hepatitis B surface antibody. What differentiates them is that reactive core IgG, indicating this patient isn't immune due to vaccination, they're immune due to past infection. And that's very important information to know because it's the only way that we can actually differentiate that vaccination from past infection, and that has implications for potential reactivation. So I've just given a few examples, and I'm pretty confident that none of them have helped us answer the question I started with, right? What is going on in this patient's case where we have this isolated reactive core IgM? How do you interpret these? So if we look at the window for HBV serologic response, you can see where we're going to have the rise in the HBV DNA with an increase in the hepatitis B surface antigen, which precludes the rise in the serologic response with the anti-HBV HBV core IgM, and then eventually converting to the core IgG, and eventually you hopefully get the rise in the hepatitis B surface antibody. Looking at this, we have really 4 possibilities for what could explain this isolated anti-HB core antibody. We could be in a unique window period where this is the only antibody present for binding. We could have resolved HBV infection with some persistent IgM core antibody. I think that's less likely, but I can't rule it out. You could have occult HBV, right? So this is an underlying infection. And the most likely explanation that we see, which is almost always going to be based on the clinical scenario, is going to be a false positive IgM core antibody. And so it is something to be aware of. While our hepatitis serologic tests are very, very good, the IgM core antibodies in particular, we tend to see more false positives. And so while they add a lot of value to understanding the patients, you want to be prepared for these scenarios to occur. So let's talk about another case, which I think highlights some unusual and unexpected results that can occur. So we'll say with a 33-year-old G2P1 female coming in for routine prenatal care at 11 weeks gestation. Routine laboratory tests with the triple panel HPV is shown below. And so we have a somewhat interesting pattern of results here, right? We have this reactive hepatitis B surface antigen, and we have a reactive hepatitis B core IgG. And as we were just talking, right, that's all consistent with a chronic infection, right? So we would think, well, maybe this is a patient with chronic HBV. But what's a little unusual here is that we also have a reactive surface antibody. So you wouldn't generally expect to see a reactive surface antibody and a reactive surface antigen, right? Because if the patient is generating antibodies against hepatitis B surface antigen, they should be clearing the hepatitis B surface antigen. And so they might be positive for the antibody, but not positive for the antigen. But we do actually encounter these patients on a, I would say, fairly routine basis. I wouldn't call it common, but at the clinic, we do a significant number of hepatitis B tests, and so even relatively uncommon things are encountered quite commonly, right? And this has been well published in the literature, and this is where we have these escape mutants, right? And so the idea is either some sort of mutation and evolution of the virus so that you have a hepatitis B surface antigen that is no longer recognized by the hepatitis B surface antibody. Thus, you have that potential for them to coexist. Or there's also some suspicion that there might be some variable cross-reactivity with the antibody that is made. But most of the data I have seen suggests that this is truly a mutation on the part of the virus, which leads to a small change in the surface antigen such that it's still recognized by our serologic assays, but it's no longer recognized by the immune system. There's a nice study out of Seoul University Hospital, which actually looked at this to evaluate whether or not these patients had worse clinical outcomes, right? Because that's something which often comes up when your provider reaches out and says, I don't understand this pattern, it doesn't make sense. And you say, oh, this is well documented in the literature, this is an escape mutant. Typically, the next question you're going to get is, what does that mean for my patient? Do I need to do anything different, right? And so this study found that there was really no significant difference in terms of long-term outcomes for these patients who are, they call double positives versus the single positives, right? So I'm not yet aware, it's not the most conclusive study, but I'm not yet aware of any serious clinical implications for the patients. But it is a confusing pattern of results, right? So before I move on to our last case, I do want to take a second here and just mention, we just talked through, in pretty rapid order, a large number of result patterns you might experience. Just a show of hands, is anybody feeling a little confused by some of the things we just went over in the last 20 minutes? Yes, yes. Let me guarantee you that when your providers get these results back in the medical record, they are even more confused than you, right? And so I highly encourage you, if you haven't done this already, make sure you're taking the time to speak with your providers to understand what they need. We have found that including interpretive comments with all of our serologic tests, and in particular, if you can give a combined interpretation of that hepatitis B triple panel test, right? You want to have that built in your medical record because that is the recommended screening test. And you can include a field that allows you to auto-append a comment based on the pattern of results that you see. I don't know how many of our OBGYNs wanted to hug me after I put that in place at a former site, but they will greatly appreciate it. And it helps avoid any misunderstanding. And it allows you, as a laboratorian, the opportunity to be communicating more actionable and insightful information to your care teams. So I'll get off my soapbox, and we'll go to our last case. So case number 4 will be a 29-year-old Afghani male with treatment-naive chronic HBV who presented to an outside facility with significant abdominal pain, nausea, vomiting, denied alcohol, drug use, magnetic resonance, choleangio, pancreatography, showed nodular liver surface, and biopsy confirmed cirrhosis with markedly elevated active chronic hepatitis, right? And you can see from the patient's drastically elevated transaminases, the significant liver dysfunction. We're even probably starting to see a hint of impact to liver synthetic function with that low albumin. And not surprisingly, we have our reactive surface antigen and the reactive core IgM, core IgG, right? So is this just a normal case of hepatitis B infection, right? Could be. Certainly hepatitis B is associated with significant liver failure, the cirrhosis, right? But there is another possibility here. And so the care team went on and ordered a hepatitis delta antibody, which was reactive, right? So hepatitis delta is associated with some of the worst outcomes in hepatitis B positive patients, right? It leads to rapid liver failure and is, fortunately, an actionable finding. There are some new treatments coming out of Europe. So if you can recognize hepatitis delta, you can actually intervene and have much better outcomes in your patients. So what is hepatitis delta? So hepatitis delta is a virus which can only exist in the presence of a patient infected with hepatitis B. In terms of its prevalence, there have been a few studies to look at this, and the studies vary in terms of their estimated prevalence with some differences in geography. But they're looking at an estimated prevalence in the US, they say, of around 5%. But I'll mention that for many sites, there's not very good data available. And in fact, we don't have great diagnostics available for hepatitis delta, right? And so I think it's always challenging to say that we don't have a problem with something if we're not adequately testing for it, right? You know, if you wanted to have a 0 COVID rate, you could just stop testing for COVID, right? And then you'd have no positives. Speaking of the misinformation talk from this morning's plenary, I would not recommend that approach. But we do know that hepatitis delta is around. It does cause significant morbidity, mortality on our patients. It uses up a significant amount of healthcare resources. And so there has been a concerted interest to try to study and better understand the prevalence of this and whether actually from a healthcare economic standpoint, it might be beneficial to test for it so we can recognize it and treat these patients before they incur the significant healthcare expenses. So I was fortunate. We were part of a study which investigated screening for hepatitis delta in the United States. We were one of many sites that contributed. We ended up having a couple different testing processes, right? Depending on whether it was a, sort of provider-initiated ordering of the hepatitis delta or whether it was a lab-initiated. I'm happy to talk more about that afterwards. I'll be able to stick around. We ended up getting just over 100,000 patients for hepatitis B surface antigen, of whom we saw just about 1,100 were positive. Of those 1,100, we were actually only able to test about 58% of them. So we had a significant number of positive hepatitis B surface antigens that weren't able to go on for subsequent testing. And I think that's a huge limitation of the study. Of the ones we tested, we identified 9 patients, and only 2 of whom were actually HDV positive. So we saw a fairly low prevalence relative to what's published. I'll also mention, though, that as we've been going back through our data, what was apparent was we did a testing of sort of convenience, right? Looking at anyone who had a hepatitis B. And when you look at risk factors for hepatitis delta, we had a very low number of patients who met that criteria. So I think there's still a lot of work to do as we think about how we should be testing for hepatitis delta, should we be testing, and whether or not that is beneficial at a population health level. So with that, I'm happy to take any questions you might have. Yeah.
Okay. But before we go to everybody else, what's your thought? We have 245 million HBV infections, but I just heard a statistics that we only have 12 million diagnosed. So there's a huge gap. Why?
So this is going to sound crazy, but it seems laboratory testing is really important. Not meaning to be tongue-in-cheek. It's all about testing and identifying the patients who are positive. We are not doing a very good job screening patients, and we're doing an even worse job screening at-risk patients. So fun fact, when I was at Norton Healthcare, something like 80% of our tests were on pregnant patients, and somewhere on the order of 90% of our positives were on male patients, right? So even though males made up a small percentage of the patients we were screening, they made up a disproportionately large number of the positives. And it's not necessarily because males are more or less susceptible to HBV. It's just that the only males getting tested were those with risk factors. And we know that there were a lot more patients with risk factors who weren't getting tested. So I don't think we're doing a great job testing, and in particular, not testing most at risk.
So another question that I had was, you showed the different cases. What do you do with a neonate or young child that is being born to a mom that has HBV? What kind of test do you do? What's the protocol that should be followed?
Yeah, great question. The question is about testing of neonates born to HBV positive moms, right? So perinatal transmission is the #1 way that hepatitis B is spread. And so recognizing it quickly is paramount. And so once the child is born, you want to initiate testing for HBV surface antigen and also initiate treatment with HBIG and start the vaccination series, ideally within 12 hours or so of life.
Any other questions that we can entertain before we wrap it up?
Thank you.
While we're waiting for questions, I think I had one more question. So we talked about peds, we talked about population, but I was intrigued. You said that you have some patients that show up, they take the vaccine, and then they walk down the aisle and get the phlebotomy on the second run. What do you do with that? Like, do you just say, oh, you just had the vaccine, this is a false positive, or do you do something else?
Yeah, it's a great question. So there was actually a really nice study done out of one of the VAs, which looked at the time course for hepatitis B surface antigen reactivity following administration of the vaccine. And so if you detect that and you suspect it is from recent vaccination, bringing the patient back and retesting in 2 weeks' time would be ideal.
Thanks. All right.
So you had brought up how labs aren't doing the testing, but yet we also need to get the message out to our clinicians to do that. What's the best practice that you did to go ahead and advance testing among clinicians so that they're going ahead and ordering these tests? Do you have an order set in your LIS to do so? Like how are you bridging that gap between the lab to do the testing, but then get it to the physicians too to make sure that they're ordering? Because when you look at ordering panels, most of the time they're taking care of, checking the OSAB to make sure that there's immunization and not doing anything else?
Yeah, it's a great question, and I wish I had a good answer for you. I can tell you one of the big things that we have tried to do is to partner with some champions. So, we had a really great population health team who was willing to actively engage with us, setting up order sets so that, tests are available. One thing we used to get a lot is this isolated ordering of STI testing, right? So, someone would be worried that they want to be tested for HIV, but they would assume they're not at risk for Hep C or syphilis, right? Which is a huge problem. In fact, Kentucky changed some of their regulations around syphilis testing because of the rise and lack of testing. So trying to make it a little more convenient for them to order, making sure that folks are aware of the guidelines, and then partnering with folks who are aligned with us and can help drive that message home. The other thing that was really helpful is, we set up some really great nurse navigators. One of the things that we found was clinicians don't like it when they don't know what to do, right? And so if they get back these results they don't understand, they're less likely to order it. So making sure the results are coming back and are interpretable and understandable, and also making sure that they know there is someone to help them should they detect chronic hepatitis B, they can connect that patient to a nurse navigator. It sounds a little silly, but they're nervous to go down roads when they don't know where to go. So making sure they know they have that support can also be helpful.
All right. Well, thank you, Dr. Hayden. Appreciate your talk.
Thank you all for your attendance.
If there's any questions, folks, stop by afterwards and we'll try to address those.